Let me ask you something nobody in a hospital waiting room ever gets asked. When was the last time a surgeon sat down with you? Not for 5 minutes with one hand already on the door, but actually sat with you, looked you in the eye and said, "Here are all your options, including the one that doesn't involve an operating room." I've been practicing medicine for over 20 years, and I can tell you, with complete honesty, that conversation happens far less often than it should. Here's what happens instead. A scan comes back, a number looks wrong, and suddenly the machine kicks in. Referrals, consultations, paperwork, and at the end of that conveyor belt, a surgery date, already booked, already approved, just waiting for your signature. Your body is not a broken appliance that needs a quick fix. It is a living system that deserves a thoughtful conversation. And for those of us over 60, that missing conversation can cost us something we can never get back. I'm Dr. Michael Adeyemi. I specialize in preventive health and risk awareness for older adults. And today, I'm going to do what I wish more surgeons would do in that office. I'm going to tell you about 5 surgeries that carry hidden, serious, and often under-discussed risks for seniors. The risks they put in the fine print, not the brochure. And more importantly, I'm going to show you that in many of these cases, you have more options than anyone told you. Stay with me through the full video, because the last 2 minutes contain something I call the 4 questions that could save your life. And I mean that literally. Before we get into the 5 surgeries, I want to tell you something about how I came to this topic, because this isn't just academic for me. My grandmother, I called her Mama Bunmi, was 74 years old when she was scheduled for elective gallbladder surgery. Routine, they told us, in and out in a day. She had kidney disease and mild heart failure, but the surgeon said she was a good candidate. She was in the ICU for 11 days after that surgery. Not from the gallbladder, from the anesthesia, the fluid shifts, the stress on her kidneys that nobody properly accounted for. She survived, but she was never quite the same woman who walked into that hospital. That experience changed the way I practice medicine. It changed the questions I ask. And today, it's changing the questions I'm going to teach you to ask. Because here is the single most important thing I want you to hear before we go any further. A surgical recommendation is not a verdict. It is an opening bid in a negotiation, and you have every right to counteroffer. Why older bodies are different. Here's what medicine is slowly, finally beginning to accept. The physiology of a 72-year-old is not the same as a 45-year-old. That's obvious when we say it out loud. But historically, surgical protocols were built for the younger body and applied to everyone. Think of it this way. Imagine you have 2 smartphones. One is brand new. One is 6 years old with a cracked screen, a battery sitting at 61%, and 17 apps running in the background. If you run the same major software update on both devices at the same time, do you expect the same result? Of course not. One might sail through it. The other might freeze entirely. That is what happens when we apply aggressive surgical procedures to an older body without properly accounting for what is already running in the background. In older adults, here is what changes during major surgery. The heart has less reserve capacity to handle stress and fluid changes. The liver processes anesthetic drugs more slowly, which extends their effects throughout the body. The kidneys are slower to clear medications and manage fluid balance. The immune system is less equipped to fight post-operative infection. And the brain, this is the one most people never hear about, can enter a state of post-surgical confusion that in seniors sometimes never fully resolves. Doctors call that last one post-operative cognitive dysfunction, POCD. Studies published in the journal Anesthesiology found it affects up to 41% of patients over 60 after major surgery. That is not a rare complication. That is nearly half. Before we continue, if you are new to the channel, please click that like button and subscribe my channel. Also, share your health condition in comments. I will reply and respond to every single comment. Now, with that context clearly in your mind, let's talk about the 5 surgeries. Surgery number 1, carotid endarterectomy in asymptomatic patients. I want you to pay close attention here because this is one of the most overperformed surgeries in older adults, and most people have never even heard of it. It's called carotid endarterectomy, CEA. It's a procedure where a surgeon cuts open the carotid artery, the main blood vessel running along the side of your neck. and physically scrapes out fatty buildup to reduce your stroke risk. When it's done for the right patient, it works. I'm not disputing that. But here is where it gets murky. In recent years, this surgery has increasingly been recommended to patients who are completely asymptomatic, meaning they've had no stroke, no warning signs, no mini-strokes, nothing. A routine scan found some narrowing in the artery, and suddenly the recommendation is surgery. Here is what the research actually says. For asymptomatic patients, the absolute stroke risk reduction from this surgery is approximately 1% per year. That means 100 patients must undergo the surgery for just one person to benefit. And the surgery itself carries a 1 to 3% risk of causing the very thing it's supposed to prevent. A stroke on the operating table, right then and there. A landmark analysis published in The Lancet found that in patients over 75, particularly those with high blood pressure, diabetes, or heart disease, the risk-benefit ratio of prophylactic carotid surgery tilts dangerously toward harm rather than help. I had a patient, I'll call him Mr. Thompson, 77 years old, retired teacher. He came to me after his cardiologist had already scheduled the surgery. No symptoms, just a scan showing 65% narrowing on one side. I sat with him for a full hour. We went through the numbers together. His blood pressure was well controlled. He was on the right medications. His actual annual stroke risk with aggressive medical management alone was lower than the complication rate of the surgery being proposed to fix it. He canceled the operation. That was 3 years ago. He sends me a card every Christmas. So what should you do? If you are told you need carotid surgery and you have no symptoms, ask this one question. What does my absolute risk reduction look like compared to optimized medical management alone? The answer might genuinely surprise you. Surgery. 2. Aggressive cancer surgery in frail elderly patients. Now I want to address something deeply uncomfortable, and I need you to hear this with the care it's intended. When cancer enters the conversation, everything shifts emotionally. The word itself carries so much weight that it short-circuits our ability to evaluate options clearly. Every instinct says, fight it, remove it, now. And I understand that completely. I am a doctor who has sat across from people hearing that word for the first time. I know what it does to a room, but here is what 2 decades in preventive medicine has forced me to understand. For certain cancers, in certain elderly patients, aggressive surgical removal can steal more life than it saves. Let me give you the clearest example I know. Low-grade prostate cancer in a man over 75. This is one of the most common cancers diagnosed in older men. And the standard reaction, even now, is often immediate: surgery or radiation or both. But here is what the data actually shows. Low-grade prostate cancer in an elderly man often grows so slowly that he is statistically more likely to die with it than from it. The cancer never becomes the threat. But the surgery? A major study from the New England Journal of Medicine found that for men over 70 with low-risk localized prostate cancer, radical prostatectomy offered no survival benefit over watchful waiting, but it did carry significant risks of incontinence, sexual dysfunction, and serious surgical complications. The same principle applies, though with different specifics, to certain presentations of ovarian cancer in elderly women, where complete surgical debulking carries devastating physiological costs for a frail body that simply does not have the reserve to recover. This is what oncologists call the curative intent trap. We pursue surgical cure so aggressively that we lose sight of whether the cure itself is causing more harm than the disease ever would have. The alternative worth asking about is called active surveillance, watchful waiting with regular monitoring, or in some cases, targeted hormone therapy or radiation with far lower systemic impact on an older body. Before any cancer surgery, ask your oncologist directly. What does the evidence say about my specific cancer type, grade, and my age and health status? Is surveillance or non-surgical treatment a medically defensible option for someone with my profile? That question alone can open a door most patients never knew existed. If you are still watching, type number 2 in comments, and if you had any surgery in past, share your experience. Surgery number 3, open aortic aneurysm repair in high-risk seniors. Surgery number 3. And this one comes up more often than you might think, because abdominal aortic aneurysms, bulges in the main blood vessel of your abdomen, are quite common in older men who smoked earlier in life. An aneurysm that ruptures is a catastrophic, life-threatening emergency. Nobody debates that. But here is where the conversation gets complicated. When an aneurysm is discovered before it ruptures, during a routine scan, for example, the surgical recommendation depends enormously on its size. Under a certain threshold, watchful monitoring is the standard of care. But once it crosses roughly 5.5 centimeters, surgery is often recommended. There are two approaches: open surgical repair, which involves a large abdominal incision, general anesthesia for several hours, and physically clamping the aorta while the surgeon works, or EVAR, endovascular aneurysm repair, a catheter-based, minimally invasive approach that threads through a blood vessel in the groin. Here is the problem. In some hospitals, open repair is still being recommended for elderly, frail patients, even when EVAR is available. Sometimes because of institutional preference, sometimes because of training gaps, sometimes simply because the system hasn't caught up to the evidence. A study published in the Journal of Vascular Surgery found that in patients over 75, open aortic repair carries a 30-day mortality rate of 5 to 8%. The same study found EVAR in the same patient population carries a rate of under 2%. That is a significant difference. And yet many patients are never told both options exist. If you or someone you love is facing aortic aneurysm repair, ask this explicitly. Am I a candidate for EVAR? And if not, exactly why not? You deserve a specific evidence-based answer, not a shrug and a scheduling slip. Has anyone in your family ever been told they needed surgery, only to later find out a less invasive option was available? Tell me in the comments. I read every single one. Elective gallbladder removal in frail seniors surgery number 4. And this one is personal to me, because of Mama Bunmi, cholecystectomy, gallbladder removal. It is one of the most commonly performed surgeries in the world. Over 700,000 are performed in the United States every year. And when it's done laparoscopically in a healthy adult with acute gallstone disease causing real symptoms, it is genuinely one of medicine's success stories. But here is the part nobody mentions when they're scheduling the surgery for your 80-year-old parent. Many older adults have gallstones discovered incidentally, meaning they weren't the reason the scan was ordered in the first place. The stones are there, but they're not causing symptoms. They are silent. And the recommendation that often follows is preemptive removal. Let's take it out before it becomes a problem. A 2022 study in JAMA Surgery found that in patients over 75 with asymptomatic gallstones, elective cholecystectomy did not significantly reduce the risk of future complications. But it did expose patients to immediate surgical risks that watchful waiting simply does not carry. In frail elderly patients, those surgical risks include anesthesia-related complications, bile duct injuries, wound infections, and the cardiac stress of even a so-called minor laparoscopic procedure on a body with reduced physiological reserve. And here is something that is rarely said out loud in that office. Many gallstones in elderly patients never become symptomatic. People live alongside them for years, sometimes for the rest of their lives, without incident. After what happened to my grandmother, I went deep into the data on this. And what I found was remarkably consistent. For asymptomatic or mildly symptomatic gallstones in a frail older adult, conservative dietary management combined with careful monitoring is frequently the safer, evidence-backed choice. If you are told you need your gallbladder removed and your symptoms are mild or absent, ask, what happens if we monitor this with dietary adjustments for the next 6 to 12 months? What does the research say about watchful waiting for someone my age and health profile? Get specific answers, not general reassurances. Multi-level spinal decompression with instrumented fusion in elderly patients, surgery number 5. And I have to be very precise here, because I do not want to discourage anyone from a surgery they genuinely need. So stay with me through the nuance. Spinal stenosis, the narrowing of the spinal canal, is extremely common in people over 65. It causes back pain, leg weakness, and that characteristic symptom where you have to stop walking and rest every block because your legs simply give out. It is genuinely debilitating, and I would never minimize that. And yes, in severe cases, surgery can be genuinely transformative. I will not tell you otherwise, but there is a growing and disturbing trend. Patients who come in with moderate stenosis, not emergency, not paralysis, not loss of bladder control, are increasingly being offered not just decompression, which is a targeted, smaller procedure, but multi-level decompression plus instrumented fusion. Rods, screws, hardware running up and down multiple vertebrae. A study in the journal Spine found that for elderly patients undergoing complex fusion surgeries involving 3 or more spinal levels, the complication rate exceeded 45%. Nearly half of all patients experienced a significant adverse event, and here is what makes this especially troubling. For many patients with degenerative spine disease, the long-term pain relief from complex fusion is not statistically superior to more conservative approaches. Physical therapy, targeted epidural injections, and nerve block procedures. Not a little better, not significantly better, the same, or in some cases worse, because of something called adjacent segment disease, where the vertebrae above and below the fusion begin deteriorating more rapidly because the natural mechanics of the spine have been permanently altered. I want to tell you about a patient I'll call Dolores, 73 years old. Former dance instructor, remarkable woman. She came in with moderate lumbar stenosis and had already seen 2 spine surgeons who both recommended a 4-level fusion. She was scared. She was also extremely sharp and had done her own research before our first appointment. We mapped out an alternative program together. Targeted physical therapy with a therapist who specialized in spinal stenosis. 2 epidural steroid injections spaced over 6 months. Aquatic therapy, because water reduces spinal load by up to 80%, allowing her to move and strengthen without pain. 8 months later, Dolores was back to teaching a gentle movement class twice a week. She never had the surgery. And she told me something I keep coming back to. Nobody ever asked me what I wanted to be able to do. They just told me what they wanted to do to me. That sentence. I keep coming back to it. If spinal surgery is on the table, ask, what is the least invasive surgical option that directly addresses my specific level of compression? And what does the evidence say about exhausting conservative treatment first for my type of stenosis? The hopeful pivot. What medicine can do now? Okay, I have told you a lot of heavy things in the last 10 minutes, and I need you to hear what comes next because this is the part that actually matters most. This is not a video about fear. This is a video about power. Your power. Because here is what is genuinely exciting about medicine right now. The non-surgical and minimally invasive options available to older adults today are more effective than they have ever been in human history. Robotic-assisted laparoscopic surgery means what once required a 10-inch incision can now be done through 3 punctures, the size of a pencil tip. Catheter-based interventions have replaced open surgery for dozens of conditions that once required stopping the heart or clamping the aorta. Targeted injection therapies for spinal pain have become dramatically more precise with real-time imaging guidance. Immunotherapy and hormone-blocking medications have transformed certain cancer management pathways that once defaulted immediately to the operating room, and optimized prehabilitation programs, structured exercise, nutrition, and cardiovascular conditioning in the weeks before elective surgery have been shown to reduce complication rates by up to 50% in high-risk patients. The body wants to heal. It was built for it. Our job, as doctors, as advocates, as patients, is to give it every possible advantage before we ask it to endure something as significant as major surgery. And sometimes the most powerful tool available is not a scalpel. It is patience, information, and the courage to ask hard questions in a system that does not always reward the asking. The 4 questions that could save your life. Before I bring everything together, here are your 4 non-negotiable questions before any major surgery. Write these down, screenshot this, photograph it, put it somewhere you will find it when you need it. Question 1. What is the natural history if I do nothing or if I delay? A good surgeon will tell you honestly whether your condition is likely to worsen rapidly without intervention, or whether it is stable enough to allow time. Time for a second opinion, time for optimization, time for thinking. That answer alone tells you a great deal about the true urgency of the situation. Question 2. What is the least invasive option that addresses my specific problem? Not the most common option, not the option this particular hospital does most often. The least invasive option available anywhere with any technology. Medicine moves extraordinarily fast. What was not possible 5 years ago may be standard practice today, at a different institution. Question 3. What does my recovery realistically look like? Not for the average patient, but for someone with my exact health profile. Your kidneys, your heart function, your current medications, and how they interact with anesthesia. Your living situation. Do you live alone? Do you have stairs? Do you have someone who can care for you? Generic recovery timelines are built for hypothetical average patients. You are not hypothetical. You deserve a specific answer. Question 4. Can I speak with a patient who had this procedure at your hands, in my age group, with similar health conditions? This question does something uniquely important. It tells you how a surgeon responds to accountability. A confident, ethical surgeon will welcome it. They track their outcomes. They know their numbers. They are proud of their record. If the question makes them visibly uncomfortable, that discomfort is itself a piece of medical information worth having. You are not asking these questions to be difficult. You are asking them because your body, your life, and your recovery belong to you, and not to the schedule on anyone else's clipboard. Let's bring it all together. 5 surgeries that deserve far more honest conversation than they typically receive. Carotid endarterectomy in asymptomatic patients, where the risk of the surgery often rivals the very risk it's meant to prevent. Aggressive cancer surgery in frail elderly patients, where the goal must always be more good years of life, not simply the removal of a tumor. Open aortic aneurysm repair, where minimally invasive alternatives are frequently available but not always offered. Elective gallbladder removal in frail seniors, where watchful waiting is often the safer, evidence-backed path. And multi-level spinal fusion, where the evidence for pain relief frequently does not justify the complication risk, and where conservative options deserve a genuine, thorough chance first. None of this means avoid surgery. Surgery is one of the most extraordinary gifts modern medicine has ever given us. I have seen it work miracles. I am proud to belong to a profession that saves lives, full stop. But between you and that operating room, there must be a real conversation. One where you know every option, where someone says your name, not just your diagnosis, where the decision is genuinely, completely yours. You are not just a patient on a schedule. You are a person with a life worth protecting in every direction, not only from disease, but from the unintended consequences of treatment. So tell me in the comments, what question would you most want to ask a surgeon before agreeing to a major procedure? I read every comment, every single one. Don't forget to press that like and subscribe button. And if this video gave you something useful, a question you didn't have before, a perspective that shifted something, a piece of information you're going to carry into your next doctor's appointment, please share it, because someone in your life might be sitting in that waiting room right now, pen in hand, about to sign something they haven't fully understood yet. You could be the reason they pause, the reason they ask one more question. And that one question could change everything. Take care of yourselves, stay curious, and never stop advocating, loudly, lovingly, and without apology, for your own health. Disclaimer: everything shared in this video is general medical information based on published research and clinical experience. Every person's situation is unique. Before making any decision about surgery or medical treatment, please have a full and honest conversation with your own physician or specialist. They know your complete history, and that conversation is always where good medicine begins.